My name is Jay Kotry. I work at Cleveland Clinic. I was asked to speak about innovations in coronary bifurcation treatment. These are my disclosures. I proctor and speak for several companies. What I want to do is I want to review a little bit of basic anatomy about bifurcations, and then we'll go through appropriate strategies in terms of selecting bifurcation treatment. And we'll go through some of the new innovations, both in terms of technology as well as techniques that are employed to treat bifurcations. So everybody's familiar with the Medina Classification. The reason I bring this up is not all bifurcations are the same, and it's the anatomy, honestly, that sort of dictates the strategy. So for example, a Medina 111, is there a pointer that I can use? Medina 111 or a 101 or a 011, that's not quite the same thing as a 100. So obviously the strategy employed is going to be dictated by the anatomy. So multiple consensus documents, multiple meta-analyses all suggest that the provisional stent strategy is, if feasible, is the way to go. And the idea here is to deploy a stent that's sized towards the main branch and then perform proximal optimization in order to optimize the strut apposition and the stent expansion proximally, and ultimately to do it in a way that you don't compromise its carina and cause side branch closure. And so we'll talk about some of the techniques that are employed to try to do that. This is just moving down the provisional stent algorithm. So you stent this, optimize the stent for the mother branch, and then you look at the side branch to see if you're happy with the result. And obviously, if you're happy with the result, you're done. If there are issues with the side branch in terms of flow, or if it's stenosed significantly, then there are several strategies that are recommended to try to alleviate the problem. The first thing is to rewire the side branch, and rewiring it, you want to try to wire as distally in the bifurcation as possible so that you can get a little flap of struts that are reopening the side branch for you. That's sort of represented by this blue line in the diagram. You want to get as distal as you can into the carina as possible to lift some struts over to open up the side branch. And there's various ways to do this. There's kissing balloons, obviously. There's a kissing balloon followed by a pot technique, and there isn't a lot of really good data yet to decide what's the best way to do this. But ultimately, you have to choose your strategy to do this. And if you're happy, you're done. If you're not happy, then there's always the bailout stent strategy. So I found this nice report that came out just last month in Euro Intervention describing a series of 106 patients with true bifurcation lesion, where they performed sort of a novel bifurcation treatment algorithm called the repot technique, where they deploy the stent across the mother into the main branch, perform pot, and then they use a balloon to reopen the side branch and then do repot. And they did LCT in between all of these steps. And what they showed is that they could improve global strut malapposition from 18.9% just after the stent was deployed down to 3.2%. And they could reduce residual side branch obstruction from 44% down to 17%. And they could reduce the ellipticity, in other words, the deformation of the proximal stent, from 1.19 to 1.13, so implying better strut apposition. And they followed these folks out clinically and had very low late event rates, and about half of these patients were left main disease. So it's just sort of an interesting, novel way of addressing this provisional strategy using only one balloon rather than kissing balloons. So what are some new technologies on the forefront that may help with these provisional strategies? So this is something I found recently in a swine model, a dedicated bifurcation balloon. And the reason that this is interesting is what they're able to do with this dedicated balloon is they can reduce the deformation of the main branch stent. They could reduce the balloon to vessel ratio from 1.66 down to 1.16. So again, better strut apposition, hopefully a better long-term result. So there's going to be some head-to-head preclinical trials with this device coming up soon, so stay tuned for that. This is also something that I just found recently that I thought was interesting. This is a stent delivery system that has an extra port so that you can wire the side branch, wire the main branch, deliver your stent already pre-wired on the side branch so that you have instant access through the strut. So it's a nice way to kind of maintain side branch access without having to actually jail the guide wires. So that was kind of interesting. So this is in the swine model right now, but stay tuned for this in the near future. Hopefully this will be something that makes it to clinical trial somewhere. So obviously that's the provisional strategy for lesions that are appropriate. For patients that need upfront two-stent strategy, there's an abundance of techniques. There's a lot of robust data for the DK crush technique. Several trials that have looked at DK crush in both non-left main as well as left main disease. So in non-left main disease, DK crush technique seems to be superior to provisional stenting. In terms of left main disease, DK crush seems to be superior compared with two-stent as well as culotte stenting. But there was a recent trial that just came out in the UK looking at dedicated upfront culotte stenting for bifurcation disease, and they followed these people out for 9 months and saw very, very low event rates. So, you know, brings some question to mind in terms of what exactly is the right way to treat these, but there's very low event rates in these dedicated culotte patients treated with modern everolimus-eluting stents. So that's kind of an interesting sway in terms of potential treatment strategy. What about tech? So this is some interesting stuff that is in the pike. This is a stent that's a self-expanding wedge that's deployed in the carina, and then it's extended using dedicated balloon expandable stents. All of it is drug-eluting with biolimus, and there's actually 5-year follow-up data on these patients showing very comparable outcomes to patients treated with culotte stents. So that's, I thought, very interesting. This is a report of left main stenting using a self-expanding sirolimus-eluting stent called Stensis. The interesting thing about this is the side branches can be ballooned and stented. You don't have to do any kissing balloons because it's a self-expanding stent. It doesn't need to have re-optimization to reoppose the struts because it's self-expanding. So kind of an interesting technology. Triton we have in clinical use in the United States. I'll go briefly in this. They basically did not meet the non-inferiority in the trial looking at Triton. It's a bare metal stent which is deployed into the side branch, and then a drug-eluting stent is deployed in the main branch. And basically, the smaller the side branch, the less clinical improvement that we saw with this. And it's hard to know whether this is really something that should be used over provisional strategy or two-stent strategy. There are other drug-eluting stents that are dedicated bifurcation stents. This is a design that's not available in the United States, which is been used in Europe with interesting design with open cells at the side branch. And a balloon that obviously does the things that we talked about. It optimizes the stent proximally, optimizes the stent distally with good angiographic result, and pretty interesting 4-year data that shows comparable results to two-stent strategy. What about bioresorbable stents? There are bioresorbable stent bench studies that show that some of these novel designs, which aren't available clinically, could be used in these advanced bifurcation techniques, particularly with provisional stent as well as TAP strategy. Drug-coated balloons have been looked at. Unfortunately, there isn't a lot of encouraging data with drug-coated balloons, either by themselves or with bare metal stents or drug-eluting stents, so I don't have a lot of positive to say about that. But in conclusion, I think that the strategy has to be dictated by the anatomy, and if the anatomy allows for the provisional stent approach is the right approach, with the aim of good stent apposition and expansion, and trying your best to maintain the original anatomy of the carina to preserve the side branch. Two-stent strategy is appropriate for complex disease, as well as a bailout for the provisional strategy. The exact two-stent technique that should be employed remains an area of active debate. And ultimately, there's all this new tech that's out there that may help us in the future in terms of how best to handle these very complex disease lesions.
Okay, thank you. So we have a few minutes for discussion. So I would like to ask you, so what's your, I mean, you gave us a very nice update on innovation. So what's your preferred strategy for bifurcations?
Well,
or you have an algorithm that you have in your mind that you use, so share with us.
Sure. I mean, I think it's what I alluded to. It's really dictated by the anatomy. If it's not a real true bifurcation lesion, then I would go with provisional stent. And then I actually have been doing the pod side branch repod technique and have been very happy with the acute results with that.
So we often obsess over the side branch, that's the whole game here. But many times if you pressure wire the side branch, it's not as significant as we thought. So what's the role of FFR and pressure wiring for these side branches?
I think that that's an important adjunct to making your treatment decisions here, because all the long-term data alludes to keeping it simple. So I think that's important.
Otherwise, you have a question?
No, so I agree. I think it's become more and more clear in the evidence that provisional stenting is really the way to go. And I'm sure all of us in our clinical practice see that as well. When you provisionally stent something, albeit there's a bias there, because we're usually provisionally stenting not to severe 111 Medina classifications. Even in a 111 Medina classification, there are differences in a 111.
Sure.
As we all know. So a lot of it has to do with the size of the side branch, and I think a lot of these technologies that you suggest, I think the true bifurcation technique, a true two-stent or a true bifurcation stent technique will work way more or way better in a larger side branch. It's the smaller side branches that really give us trouble, the 2.5 millimeter and below side branch, and those are the side branches I think that we really don't know what to do with, and I think that's I'm curious to see what the rest of the panel feels in those smaller side branches. In a 3 millimeter side branch, I think everyone would agree, if you have significant disease in the osteum, you're going to probably end up using a two-stent strategy.
Yeah, the Crichton trial data sort of corroborates what you're saying. The smaller the side branch, the worse the outcomes in terms of binary restenosis rates. So, totally agree with you on that.
So I'm a little bit disappointed because here in the US you showed lots of new technologies and lots of new things, and the biostent being available. I used it once in Mexico, and that's a polished stent, and it worked in the left main, but there's lots of other developments, and I don't see a clear regulatory pathway to get all these technologies in our hands.
Yeah, no, that's
so
definitely
we're going to
a hurdle.
continue to do DK crash 2 stents, continue to innovate on site in the cath lab, but not having access to the real innovations.
Totally agree with you. It's a challenge. It's been a challenge. I mean, it's stuff that I trained as a fellow 12, 15 years ago, we're just now getting on clinical. It's a challenge.
So I thought that was a great overview, and I think you've convinced the audience that we want to do single stent whenever we can. And I wonder, in your experience, or maybe some other people's, how often can you, and how often do you sort of know up front you're going to need a 2-stent strategy? And that sort of leads to the follow-up question, which is, what about your access strategy? Do you favor groin and larger sheaths if you have a good sense that you're going to be doing bifurcations? I know you can do all the kissing balloons from the wrist,
Yeah.
but
I'm a radialist. I do just about everything radially with 6 French. I'll use a 7 French lender if I think I need it. But just about all of these techniques I think can be handled pretty easily through a 6 French guide.
So
radially.
it doesn't influence your decision
No.
about access.
No.
And then the first part, how often do you go in hoping for a single stent, and in your mix, how often does it wind up being a...
I think that in our practice, it's almost always the hope that we'll go with a single stent, and we really gauge it on the amount of ischemic burden before we decide whether we're going to really dedicate somebody to a 2-stent strategy, because most of the time, as other panels have alluded to, you can get away with 1 stent, even in a Medina 111.
I think there is a role of debulking as well ahead of time to prevent plaque shift, and that can avoid that second stent sometimes.
Yeah, those are good points. I think any comments from the audience?
Just a debulking question. When you debulk in, say, like left main, LED insert, debulk goes from Ostia on the circ and the LED, or could it separate debulk?
Yeah, I think it depends on the severity of the stenosis at what you're calling the side branch. If it's LED circ, I mean that's potentially a big side branch, and you may debulk both. But if it's a diagonal, just debulking that LED sometimes is all you need to do. And by debulking, I mean rotational atherectomy, more so than even orbital. But just get that lumen created, ablate some of that plaque. And there are data, I mean, there are data supporting less plaque shift with rotational atherectomy in the main branch.
So I think we're past the time, 1:46. So we're going to go to the next lecture.
Thank you very much.
Thank you. Thank you so much.
So our next talk is Innovation in Managing Severe Calcification by Perwaiz Miraj from New York.
Good afternoon. Thank you very much for the organizers and the panel and our moderators for inviting me to give this talk. So my topic was innovation in managing severe calcium, and as we all know, there's been a decent amount of innovation in the past. I'm just going to do a quick review. As everyone knows in the room, in the audience, prevalence of calcium is increasing. We're seeing more patients with it, and now as our CHIP population goes ever increases, we're seeing a lot more calcification in our coronary vessels. And we know that there are a lot of complications due to coronary calcification. We know that the vessel is prone to dissection when you do balloon angioplasty. We know lesions are typical to completely dilate. We know stents don't adequately expand, especially when you do intravascular imaging, as you'll see on the right of your image. And you can prevent stent delivery if you're unable to truly debulk the calcium that's there. And you really have uneven drug distribution that's really associated with restenosis, which has also been shown as well. And we know that the presence of coronary calcium really portends to worse outcomes. This is from the Horizons and the Acuity data set. As you can see here, a total of 3,000 STEMI and non-STEMI patients. You can see here that severe calcium definitely had the worst outcomes to overall MACE and going through the entire gamut. And we know that angiography underestimates calcium, and I think as we've seen in the last couple of years, a very significant uptake in intracoronary imaging, and I cannot stress this enough, what we see on angiography definitely does not really tell the whole story, and we really need to do more and more imaging to really tell the whole story. But once in a while, you do see coronary imaging, and you'll not have to really do much to tell that you have a lot of calcium. When you see railroad tracks going down your vessels, you know that you have a lot of calcium, as you can see in this RCA. You can see the vessel without contrast, and you can see in that LAD, when you see the vessel without contrast, you know there's a lot of calcium. And we'll talk about this. So we know that Rotablator, tried and true tested, has been around for over 25 years. Really a catheter-based interventional technique, high-speed burr. It's diamond-coated on the front tip, ranging in size from 1.25 to 2.5 millimeters. And it's been used for a very long time for debulking and improving PCI success. Orbital atherectomy is a relative newcomer on the block. Its orbital mechanism uses differential sanding. It's something that's been available for the peripheral and for those who do peripheral vascular debulking interventions for a while now. And I'd say in the last 5 to 6 years, it's actually increased in uptake in the coronary vasculature. And you can see here that it's extremely effective in doing what it used to do in the peripherals in the coronary world as well. Both Rotablator and CSI, or Diamondback, or orbital atherectomy. You can see here that the difference is really Rotablator is front cutting, CSI Diamondback is differential circumferential cutting. You can see here that the range of sizes for Rotablator in terms of its micron sizes are anywhere, in terms of its burr sizes, are anywhere between 1.25, like I said, to 2.5, whereas the Diamondback comes in one single catheter with 2 different speeds. Is a 1.25 catheter size, and depending on the speed, if you go up to 120,000 RPM, you can get an arc, depending on the vessel, as large as 1.9 millimeters. The size and the exposed diamonds and the grit size are, of course, different between the two. However, and the mechanism is very different. However, the overall outcome is what we're trying to be the same. So we actually at Northwell had to have an ongoing registry, which is now almost 2,000 patients large, but this is our report from the last 1,000 patients that was submitted and published earlier this year. You can see here that we had a total of 474 matched patients in the rotational versus the orbital arm for lesion characteristics, and you can see here that procedural and safety outcomes were very good across the board, fluoroscopy time being a little less with orbital atherectomy. And if you look at the primary and secondary outcomes, with the exception of an increase in a higher number of rotational atherectomy mortalities, which in the end, when you did a non-inferiority analysis, really showed to be no different. You can see really here, across the board that really myocardial infarction was the biggest one. And you can see the difference between orbital and rotational atherectomy. But the goal of that paper was not really to show one device was better than the other. Really, the goal of the paper is to show this. This is what the temporal trends have been in our use of orbital rotational atherectomy. You can see here when orbital atherectomy started its play in 2014, you can see the uptake in the number of cases per year of orbital and rotational atherectomy that are occurring at our institution. And this is probably, we are not in any way unique to this. This is happening across the board because we're able to do things that we weren't able to do, ranging from taking care of more complex lesions, using better bifurcation techniques, hemodynamic support, you name it. So lesion characteristics in terms of looking at the two vessels, we put together a few slides to say, hey, what are the differences? One would use one versus the other, albeit you could say you could use both in almost all cases. I'd say larger the vessel, orbital may be more effective because you can use one burr and change the speeds rather than changing burrs. Smaller the vessel, rotational, in my opinion, is definitely safer, engages smaller vessels better. And with tortuosity, I'd say the same. Rotational atherectomy definitely, because of its floppier wire, definitely tracks tortuosity way better than orbital atherectomy. However, less tortuous vessels, they're very much the same. More tight concentric calcium, as we all know, orbital atherectomy does not front cut, whereas rotational does, so therefore you have that front cutting engagement of that very tight concentric calcified lesion. And orbital osteo lesions, we'd say that right now rotational still remains the ideal choice for that osteal RCA or osteal left main, albeit there are many people who use orbital atherectomy in that scenario. You can see here in a certain case, here's a very osteal RCA calcified lesion and a mid-calcified lesion. This is a case that a patient with a very low EF, so we use hemodynamic support. And you can see here both for rotational atherectomy, the osteal lesion going all the way through, we were able to successfully treat this lesion. Another thing that we have to always keep into account, and I'm sure fewer and fewer of us are using pacemakers in doing these atherectomy cases, and you'll see here that we published this back in 2016 at ACC, and this suggests that orbital atherectomy actually requires less pacemaker activations than rotational atherectomy, and it's something that people have been seeing all throughout. Atherectomy also, the orbital atherectomy has bidirectional atherectomy, whereas rotational really only goes in one direction, so the pecking order and the technique is very different between the two. And the concentric motion allows for more flow, during the orbital motion allows for more flow during orbital atherectomy, which may theoretically decrease renal reflow and may be the reason why our pacemaker activations are fewer. In prior stents, we try to avoid using orbital atherectomy if at all possible, and rotational atherectomy still tends to be the standard choice. So this was supposed to be an innovation talk, so I spoke about orbital atherectomy, but I think you cannot not talk about other ways of managing calcium, albeit atherectomy is currently the mainstay and is currently the only FDA-approved method and mechanism of doing it. Lithoplasty, as we all know from the shockwave balloon, as you see here, it's a balloon with essentially very much similar to lithotripsy. We have shock waves, and it actually fractures and fissures the calcium. It's essentially a generator connected to a cable connected to the catheter. As you can see here, the sizes of the catheter are listed throughout the right here. 12 millimeter length balloons. And you can see here, you one-to-one size your balloon, you inflate, you pulse the device, and as you see, the balloon inflates and the calcium fissures, and your balloon continues to inflate. And as you can see here, that's the result after 10 seconds of lithoplasty. The angiographic outcomes in their initial study, as you can see here, the mean luminal diameter pre and final, as you can see, are very significant, and the acute gain is very significant. And you can see here overall, most importantly, the angiographic complication rate is extraordinarily low in terms of no reflow, slow flow, obstruction, and perforation. There's a Disrupt CAD2 study, which is currently in its infancy, really looking at stable, unstable angina, silent ischemia, looking at moderate to severe calcified lesions, and looking for lesion lengths less than 32 millimeters. And the really objective is to assess the safety and performance of this lithotripsy in a real-world registry, looking for 120 patients across 15 sites. So in conclusion, lesion-specific differences using rotational orbital atherectomy exist. However, they're currently the two mainstays of therapy for calcium. We are waiting and we're really eagerly awaiting the Eclipse trial, which will hopefully give us an idea of what the differences are between plain old balloon angioplasty versus atherectomy in these very calcified lesions. Albeit, I think most of us would say that in these very calcified lesions, there's a significant crossover rate from balloon angioplasty to atherectomy. So I don't see how atherectomy is going to lose there. Concentric calcium can be difficult for orbital atherectomy, and then, as was said by the speaker earlier, really there's no reason why you cannot perform atherectomy radially. It's what we do in our clinical practice all the time, and given the fact that orbital atherectomy has taken it for larger vessels, it's the advantage that you don't have to go over a 175 burr in many cases if you're going to use rotational atherectomy, and you can do everything radially through 6 French guide. You don't even need to upsize to a 7. And unfortunately, as we all know, we're unlikely to ever see a head-to-head randomized study for these two devices. This is probably going to be all registry data and what we see. So. Going back to those two first cases, just to say, I'm curious in the room, how many people would have used rotational atherectomy for this tortuous RCA? How many people would have used orbital atherectomy? I convinced everybody? No one's using orbital atherectomy? All right, so we used a rotational atherectomy. We did place a pacemaker given the size and the dominance of this RCA, and it was activated. As you can see here in that LAD, you can see this LAD shot. How many people would use rotational or orbital atherectomy, or would anyone use one in particular? Curious. Rotational? Anyone? Rotational? Orbital? I think this is one of those cases where you could use either, right? This is not a kind of case that you'd have to pick one versus the other, given the tortuosity and given what I said. So we ended up using orbital atherectomy in this case, and this is our final result, as you see here, of the LED lesion. Just more examples. You can see here another rotational atherectomy case, slightly more tortuous vessel, concentric calcium, very heavy, bulky calcium, especially in the proximal RCA, and that's what it looks like at the end of the rotational atherectomy run and stent placement. And that's it. Thank you very much.
That's great. It was interesting to see the responses in terms of whether people would choose orbital or rotational. And I wonder what your thinking is now. I know it's new, but how are you fitting the shockwave lithotripsy into that? There's a third choice.
There's a third choice there. So we really haven't taken on shockwave lithotripsy in large numbers as of yet. We're still in the infancy in our institution of understanding the device and getting a feel for it. So at the present time, we're still a very large rotational and orbital atherectomy shop in terms of truly debulking lesions. Where I think I would say where I think shockwave is going to be a real game changer is in those patients in whom stents are placed, where there's a lot of calcium behind those stents, where you didn't debulk up front and you didn't do what you should have done up front, and you need to now expand those stents. I think we've all done those 40 atmosphere non-compliant balloons, hoping that balloon wouldn't burst, and we tried using chocolate balloons and other balloons that are very...
That's been the role of laser, huh? We nuke it with the contrast and
Correct.
we laser it
Right.
and to deploy and stents that cannot be expanded.
Absolutely, yeah. The spectranetics may kill us for saying this, but what's called laser bombing, right? You essentially use a laser catheter, for those of you who don't know, and you give contrast as you're running the laser and you park it. It superheats the contrast, causes a significant reaction with the contrast, and essentially explodes. In that explosion, you're attempting to fissure whatever's back there. It's very effective for fibrous plaque behind stents. It's less effective for calcified plaque, but it is something that we have been doing.
So my pacemaker use has really dropped considerably. Do you use pacemakers in most cases? We use aminophylline 5 milligrams per kilogram about 5 minutes before we start atherectomy. Yeah,
so for our rotational cases, we are doing that now. With all honesty, in that paper I presented to you earlier, that we really have seen less than a 1% activation of pacemakers with orbital in the RCA. It's probably something to do with the mechanism of how it works. It's the only explanation I have, because the same RCAs, if you roto versus you do orbital atherectomy, you definitely see a difference in terms of its heart block.
With the difference in the particle size that's created by orbital atherectomy and rotational atherectomy, do you recommend more aggressive anticoagulation or a bolus dose of 2B3A with either of them?
Not really. I mean, I think what we do typically is any atherectomy we do, you're at a risk. I don't care what device it is. You're at a risk of no reflow. We pre-treat our no reflow with whatever drug of your choice is, nicardipine, whatever you decide to use. We pre-treat. We do our atherectomy. We treat again. But we don't change our anticoagulation strategy. I don't know, I'm sure everyone in this room feels that our 2B3A use for non-large thrombus burden stem use is almost zero. We very, very rarely use it.
There's one question there from the audience.
Just a quick question.
I'm sorry.
What about with guide catheter extensions? If you have guide catheter engagement issues or extensive tortuosity, you want to extend your guide catheter beyond it. Do you prefer one device versus the other if you have a guide catheter extension in place?
If you have a guide catheter extension in place, you're probably equally as likely to use a smaller burr, a smaller rotational burr, and an orbital atherectomy device. We typically we try to avoid using guide catheter extensions with atherectomy, I'll be honest with you. It's not that we've never done it, we really avoid it. Most times you don't need a whole lot of guide support for atherectomy, which is the advantage of it.
You know, sometimes you get into these issues where you have a distal right that's tortuous and heavily calcified, and you just don't have the push.
Right.
You just don't have the push, and that's the example I'm thinking of. I actually did one yesterday.
Okay.
I had to put a guide extension all the way to the base of the heart.
Right.
And I use CSI. I like to use CSI in that situation.
Right. You can use a 6 French. You can use a 6 French guideline or a Guidezilla through an orbital atherectomy device. It is doable. You definitely will lose all pressure ability to sense your pressure. So just be aware of that too.
In your case, do you feel like if it's that far distal, you're less likely to get the CSI stuck versus a rotablator burr stuck?
You know, it's a thing that we debate in the lab all the time because, you know, the rotablator, it's cutting immediately, right? Because it's cutting elements are at the leading edge, whereas the CSI doesn't have a cutting element at the leading edge. So I feel like if you want to use CSI, you need to have very good support to make it work, especially if you're going distal. And I found guide catheter extensions work just fine with it.
Mm-hmm.
One more question.
Sure. I mean, that's a whole long discussion about the use of mechanical support. We do a lot of mechanical support for our high-risk complex cases, but I'll tell you the cases that are the most fruitful for using mechanical support are those atherectomy cases. Atherectomy is a complex beast that's beyond just regular. You can honestly probably get away with a left main that has a low EF. Well, without atherectomy than you will if you use atherectomy and try to not use support. You're not going to get away with that case as easily. There is something that atherectomy does to the whatever remaining reserve you have in those low EF patients that doesn't make them happy. And without having that hemodynamic support, in my opinion, we pretty much, if we have a low EF, heart failure or shock type of patient, and if you have to use atherectomy, it's a no-brainer. There's no reason to not use mechanical support in that kind of case. I think we know that from PROTECT 2, right? We know that from a lot of the literature that's been published since then, that atherectomy is a beast to itself.
Thank you.
All right, thank you.
Thank you.
So our next talk is Innovation in Left Main PCI by our co-moderator, Mauricio Cohen.
I feel a little bit tall here. I don't know. Okay. Thank you. So these are my disclosures. Good afternoon. Thanks for having me here. It's always a pleasure to be here at the second CVI. So we're going to talk about left main intervention. So I always like to illustrate these kind of lectures with a case. So this is a 74-year-old that was referred to us from the west coast of Florida with diabetes, all the comorbidities, one amputation in the left leg and a right iliac stent, lateral wall MI in the past with the previous PCI total circumflex. She presented now with a non-STEMI with EKG changes, positive troponins, certain degree of CKD with a GFR of 33. She had a small radial artery with ultrasound and a 2.5 to 3 millimeter left radial artery. So the STS score was about 4%. So this is the ejection. You can see there the ejection fraction. So she's very well preserved, and she has kind of a small cavity there. And this is the angiogram. As you can see here, there's a 1-1-1 Medina Classification lesion, plus there's additional disease in the LAD and in the proximal circumflex. The syntax score was 29. We called the surgeon, and the surgeon said no. So we were faced with doing this case, and we need to understand when we are talking about left main that it's a little bit of a different animal. It's a large vessel, has a curved course, has an oval and an angled ostial shape. Usually the lesions are not restricted to the left main but extend to the proximal branching vessels. And then this angle will determine also the type of technique that we will use for the case. And we cannot, when we have complex lesions, we just cannot just get away with one stent in many cases because the circumflex will subtend a large portion of myocardium. So the rules are slightly different, so we still need to have a heart team discussion. We gotta come up with a stenting strategy depending on the location of the lesion. If it's in the ostium or the shaft, it's easy. If it's in the bifurcation, then we have to use the techniques or start thinking about the techniques that were discussed before. And then imaging is also critical in these cases, either by IVUS or OCT. And I also like, because I've been doing radials for a few years now, I always like to focus on access safety, but not only just by doing transradial, but also by doing best practices in femoral access, or now with axillary access if we need to use support. So this is a nice illustration on how the heart team discussions should go and what would favor PCI versus what would favor CABG. So if the patient is at high surgical risk or have serious comorbidities, or it's urgent, maybe favors PCI. If there's low ejection fraction, diabetes, need for concomitant cardiac surgery, then favors CABG. Then if the anatomical factors are favorable for PCI, like ostial or shaft or isolated left main, so that's okay. If it's extensive CAD with in the higher tertile of the syntax score, then we may favor CABG. And then we have to consider some of the preferences of the patients. So this is what the guidelines say. This is a nice illustration in this JACC interventional review published last year, and shows that the Europeans are a little bit more liberal with their definition of their indications in patients with left main, and they put for the low syntax score PCA at the same level of CABG. Here in this side of the Atlantic, I think our guidelines committees are more conservative, and PCI just gets a class 2 indication. For high syntax score, PCI has a 3B indication, so it's not recommended, except for patients who have a very high risk, like an STS of more than 4, age more than 85, and severe comorbidities. So there was a recent publication in Lancet of a meta-analysis based on individual patient data, and it shows that for left main disease, the outcomes at 5 years are almost similar. I won't say the word equivalent, but they are very, very, very similar. You can see that the curves overlap here, and then there's no interaction by the extent of disease as measured by the syntax score, and there's also no interaction according to diabetes or no diabetes status. So we can use PCI, and we can have those discussions with our patients and our heart team. But we don't want to forget that PCI is associated with less stroke, MI, bleeding, renal failure, prolonged intubation, and arrhythmias, and those are all comorbidities that affect the patient and prolong hospital stay and affect their quality of life, even though the quality of life may catch up after 1 year for the surgical patients. Instead, in terms of how do you want to do the case, you want to select your best stent available in your shelves. So this is one example, the Noble trial versus the Excel trial. They use different stent technologies, and the stent outcomes were quite different. So that's one thing to keep in mind. In terms of imaging, this is a very important rule. I would say that if we are going to do left main, we need to do imaging and interpret well the pictures. This is a pooled analysis of 4 registries in Spain that shows that the outcomes are in terms of MACE are significantly improved in patients in whom intravascular ultrasound was utilized. In the Excel trial, IVUS was used in about 74% of the patient, and in half of them, it changed what the doctors did. They used a larger balloon, they post-dilated, they used higher pressure, they treated stent under expansion in certain cases, and that led to a planned 2 stent strategy rather than provisional 1 stent. This is an old paper now, but it shows what are the measurements that you need to achieve when you stent the proximal left main, the polygon of confluence, the LAD, or the circumflex. And with good expansion, the outcomes are very good, and when stents are underexpanded, the incidence of in-stent restenosis is significantly higher, 24% versus about 5% plus without underexpansion. In terms of malapposition and whether or not, because we obsess about covering the ostium, it's not that important to cover the ostium or to fully oppose. The only thing that you want to avoid is having an underexpanded stent. So that's one of the teachings that come from this paper from Korea. In terms of the algorithm, so we want to make sure that we separate complex lesions versus simple lesions. The simple lesions are going to be done with the provisional stenting strategy in general, and then if we have compromise with low FFR or less than 10 TIMI3 flow, then we can use a bailout 2-stent strategy like a TAP technique or a culotte technique. The other use for 2 stents, decay crush seems to be better than culotte, provisional stenting. And in complex lesions, always guided by imaging, that's the technique that should be used. The DK Crash 5 trial was published last year, and it shows that all these patients benefit from the two stenting technique, but this technique is complicated. It involves about at least nine different steps, and you have to keep in your mind. What I do is I just print them in a paper and I have the tech, or I just take it to the radiation protection so I can follow each one of the steps and I don't forget while the fellows are talking to me. In this paper it shows that either simple lesion or complex lesions did a little bit better with DK Crash, and there was no interaction. But it seems that it's better to use it in the more complex lesions. What was done in the Excel trial, provisional stent was used in 2/3 of the cases, while plan 2 stents was used in about 1/3 of the cases, and DK Crash was not utilized because it may be proceeding, or doctors that the operators did not prefer not to do DK Crash because of the complexity. So going back to our case, this is a complex 1-1-1 bifurcation in the left main. This is the abdominal aortogram. So there's an amputation in the left side. There's significant disease in the right side. So in this case, we decided to go with 6 French. This is a statement from the left main bifurcation club that everything can almost be done via 6 French with a 6 French guiding catheter, and there's little you cannot do with 6 French. The only thing you can't do is put a burr of more than 175 or 2 kissing stents, except for the synergy. Everything else can be done. Even you can put a coated stent, a PTFE stent, to cover it in case of bifurcation. So in this case, we debulked the circumflex and the LAD. We used the circumflex because it was a little bit larger as our main branch. So this is how severely stenosed was the proximal circumflex after rotablation. Then this is post-rotablation pictures. Then we did initially LAD stenting. That was what we used as. Then we crashed the first stent. Lots of steps. We use these are very useful papers. Then we recrossed into the circumflex, and we recrossed into the circumflex to do the first kissing balloon. Here we're doing the first kissing balloon inflation with 2 non-compliant balloons. Then the side branch wire is removed. Then we do the second stenting. Then we do proximal optimization technique just to facilitate wire crossing into the previously placed stent. I know it's complicated. Then we go back again with a wire to recross into, in this case, into the circumflex. Second kissing balloon inflation. Then we repot just to make sure that we have good stent apposition and expansion in the proximal side. And this is the final IVUS. Even though it's hard, sometimes you don't get to expand as much as you want because these vessels are really hard, and there's no much. I don't know if there's going to be a role for a shock wave. But we covered all the way up to the Osteo. So these are the final results. The patient did well. And the interesting thing is that I didn't mention what the access was, but in this case, it was my first left distal TRA because the patient was obese, and ergonomically it would be hard to do it from left radial. So we used the snap box approach, and this is I'm sorry for the sound. But this is the hemostasis, and it's very simple, and patients really like it. And the staff also likes this approach. So just to show, and I don't think it's that painful in that case. I mean, the patient had been whining throughout the case like that, so that put additional stress into the case.
That's easy for you to say, right?
Huh?
That's easy for you to say.
Yeah. That's right. So anyway, so as conclusion, so you always want the heart team endorsement. You need your surgeon on your side. Use your best stent endorsed by data. There's lack of an available. We discussed this in this session for a dedicated bifurcation stent for the left main. You need to know the devices and the bifurcation techniques. DK Crash seems to be the preferred strategy. Always image, and you always practice best access and safest access. Thank you. questions?
Could you comment on this latest sub-analysis of the Excel trial looking at the incidence of late revascularization rates in mid-shaft versus distal left main disease? Are you familiar with that data? Have you?
I'm not that familiar with that data, but I'm sure that
I mean, it sort of marries nicely with our two talks about how the more complex the disease, the more likely they are to have events. Patients that had, in the Excel trial, they did a sub-analysis looking at those late revascularization rates, and it's almost all tied to patients that had distal left main disease. Patients with mid-shaft and osteo left main disease, they did just
they do just well.
Just as well.
And then there's more data on the residual cross-sectional area. The smaller the cross-sectional area, the smaller the residual cross-sectional area, the worse the outcomes. So we need to use our best strategies and achieve optimal image-guided results.
Sorry, another question.
Yeah.
When you're talking to your patients about the option between surgery and bypass and your simple left main stenosis, are you offering that to them, or?
I am, and we call the surgeons usually. Sometimes you just try to, you already have access, you already set up. If it's really simple, you call the surgeon. If the surgeon says, I want to have a discussion with this patient, we'll just take the patient off the table. If the surgeon looks at the case like in this situation, we didn't do this was a staged procedure anyway, the one that I just presented. But we try to keep, and we have a special cath conference to discuss these cases.
Does diabetes factor into that decision, or that is taken off the table, or is it simple osteo left main stent?
I think we will still call the surgeons, and diabetes may factor into that decision, depending on the degree of LV dysfunction. But this is practices, and not practice is not always married to hard evidence anyway.
Any other questions?
Okay, thank you. Okay, so the next speaker is my co-moderator, Dr. Kendrick Chunk, and he is going to talk about innovation in saphenous vein graft interventions.
Let's see. Thank you very much for this opportunity to participate in this course. It's been really great. What I thought I'd do is I'd present, in terms of a little fable, a tale of 4 vein grafts to illustrate several of the decision-making points that come to all of us as we deal with vein grafts. So this first one, hopefully, is the simple one. This is a 69-year-old male veteran. He's had a prior CABG. He comes in with an on-STEMI. He goes to cath. He's got really not much other than this focal lesion and a vein graft down in the distal part of the body of the graft. Fairly small target vessel, a little bit diffusely diseased. And I think most of us would probably treat this vein graft in that setting with an on-STEMI. So because this is a right graft, we tend to use a multi-purpose guide, use embolic protection essentially every time. Stent goes up, filter comes out, nice result. I don't think there's any argument, hopefully, although the marketing data would suggest that people don't necessarily believe in embolic protection, but I hope people realize that this is the perfect case for embolic protection, stent, and get out. So the lesson on the first patient is when it's simple and focal and the alternatives are not, that right coronary was completely occluded all the way down, treat the SVG. And when you do treat it right. Use a proper guide catheter for the vein graft that you're treating, and use embolic protection. And there are a couple different options on the market. You should get familiar with at least one of them. So case number 2, this is another patient about the same age, 70-year-old guy, prior CABG. He's had multiple prior PCIs. His cath shows a patent left main into circ, a native right coronary that's patent, and a lima to the LAD. His culprit for this presentation is going to be a vein graft to the ramus. And this is a case that Actually, one of my colleagues did initially. So here's this left main into circumflex. And you can see, as we look at it in the aerial view, there's a stent dangling up there in space, and that, I'll just tell you, is going to go to a large ramus branch. We've got a lima to the LAD. There's a little bit of apical, very distal LAD disease, but this thing is patent. So their thought was, this is actually severe ISR. Somebody else had previously treated this. ISR, and a lot of thinking is if it's ISR, you don't necessarily need embolic protection. You can just go in here quick and easy and treat this. Okay, so that was the plan. Here it is in another view. You see it's very tight. They go in with a little bit undersized balloon. A good choice of guide, I'll comment. That's an Amplatz guide, a very good choice for a left graft. They pre-dilate it. Everything's looking great. Lots of flow there. You go to put the stent in, and then they take this picture after the stent. And so if anyone thinks that you can look at an ISR lesion and say, I don't need embolic protection, you should think twice. So they struggled for a while. Patient got pain and soft pressure and everything. But after lots of working with doses of nitroglycerin, nicardipine, and so on, eventually got this flow at the end of the case and got out of Dodge. So the same patient, 6 months later, comes back with return of his symptoms. Turns out he has recurrent ISR in the same exact spot. So this time, we didn't want to be bitten twice by that same vein graft, and we decided to abandon the vein graft and open the native vessel, but use the vein graft to our advantage. So here we have two Amplatz guides. We've got a microcatheter and wire in the vein graft that's going to the ramus, and we've got a guide that we're going to use in the native left circulation. So here's an injection into the native left. You see the wire has traversed down through the lesion and is coming back in the target vessel toward the occlusion point of the ramus. So just another view on that. So we're working away on this and making some progress. We've got some antegrade gear in here with a support catheter and a wire, so we can, the idea being that we're going to probably do a reverse cart here to connect these two. And the patient starts developing 8 out of 10 chest pain and ST changes. Well, we're working through a very tight lesion, and he's very dependent on that. So we had to pull out, abandon that for a little bit, balloon it just enough with an undersized balloon to get some flow, and then resume the procedure. And at the end, I won't show the details of the reverse cart, but we have a reasonable result confirmed by IVUS that we have well-expanded stent in the left main, reconstituting the native ramus, abandoning the vein graft. So the lessons from that is some vein grafts are best abandoned, but they do make great retrograde conduits for reverse cart CTO PCI. So a third example, this is a patient, 67-year-old man with a positive MPI, some angina, EF that's a little bit depressed. He's also had prior cabbage. He's got patent native right coronary, a lima to his LAD, a CTO of his circumflex, and a vein graft to the circumflex that's 100% occluded. So when we look at this, this is dual injections, again with dual guide catheters, dual groin access. He's actually got probably native, originally had left dominant circulation. This is probably a non-dominant right, but it's developed such a large collateral you almost can't tell. And so he's collateralizing the circumflex largely from the right coronary, and you can see the stump of the vein graft in that obtuse marginal that backfills a little bit. So believing that collaterals are never adequate to prevent ischemia, we tried to open this antegrade, and as you see on the initial attempts, the wire goes offline and we're in a subintimal space, certainly not in true lumen here antegrade. So we try, and I'll just show both of these if they'll both play. The one on the left is, of course, that original angiogram, and we thought we'd try to traverse that big, huge collateral and get to the circumflex that way. And I don't know if you can appreciate, down in the corner on the original image, there's almost a loop-de-loop right as the vessel folds over on itself. And we just could not get a wire and a support catheter to track through there, so I had to abandon that. So this is just going to be a fluoro save. Here we are, we'll do a little puff into the vein graft. This is a completely occluded vein graft. This is the other end of the one that goes to the OM that we saw filling in the other way. So I just saved the whole fluoro thing to show it's really not that big of a deal usually to get a stiff wire. I don't remember which this was, maybe a Guy a third or a Confianza Pro are sort of the typical ones we'll use. With a support catheter, a little bit of pushing, a little bit of torquing, and you can penetrate the cap and make some progress into there. Then you can bring in the support catheter, which is what we'll do here. And you can switch to a wire of your choice. Often all it takes once you penetrate the cap is maybe a Pilot 50 or something like that. You can get down the vein graft, and it's not as challenging as a lot of people think it might be. Bring the support catheter down. Now I like to inject, once I get most of the way down, I like to inject and see what's down there. It's a little controversial, I guess, but I like to see that stump that I saw before and make sure everything's connected. So notice we've parked the wire in the antegrade, the one that's offline. We're just injecting through the retrograde, through this occluded vein graft. And then again, after that injection, again, just a fluoro save, just showing that we can wire down from that point in the mid-graft and easily make the turn and go back up toward the other wire. So it's, and then in this case, we were thinking we were going to do reverse cart, but actually the wire went all the way up. You'll see us fiddling with the retrograde wire. We're pushing, the wire goes into the aorta, so we just pull the wire back a little bit and redirect, and the wire goes, you'll see in a second, straight into the guide catheter. So sometimes you get lucky and there's no need to even do the reverse cart step. The wire will go in right now, I think, hopefully. So once the wire goes in there, you can just externalize the wire and work antegrade and balloon and stent, and there's the final result. So actually a fairly expedient, not a super long case. So not all large collaterals can be traversed safely. A lot of times these collaterals look really juicy and big, but you can't really get through them. And 100% occluded vein grafts can be a great retrograde conduit for PCI of a CTO. Remember, though, that the completely occluded vein graft itself is still considered a class 3 by the AHA. I think there are limited circumstances where you would actually open that vein graft and try to get a durable result when it's been completely occluded. And then the final patient that I think illustrates some other decision-making points is this is an 80-year-old veteran with angina and a non-STEMI, prior cabbage again. And this patient has a series of issues. So a patent left main into the circumflex, which is an important vessel for him, with a high-grade lesion in that left main. A lima to the LAD with a 100 millimeter left subclavian artery gradient, tight lesion in the left subclavian. And then a vein graft to the ramus with high-grade stenosis. And I don't know what your practices are like, but often we get sort of one crack at these patients and we want to do the most benefit that we can in their visit to the cath lab. So here's that left main, tight lesion. It looks tight in this view, looks even tighter in the RAO view. And you can see there's a circumflex coming off, that little bit of competitive flow coming down a septal perforator there. And in the LAO-cranial, you see good delineation of what that left main issue is. Technically protected because there's a lima to the LAD, but as I mentioned, not really protected because there's a subclavian lesion, which is here. So again, high grade, when we crossed it with a catheter, the pressure was 100 millimeters lower on the other side of it than it was on the proximal side. And this, once we engaged it, you see it's a fairly large LAD. This is collateralizing the PDA, but that's going to be for another day. I can't do everything in one day. And here's the native right that's occluded. This is another vein graft that's occluded. So here's the culprit vein graft to the ramus. So we could do something fancy like on the prior case and go through that and try to reconstitute the path to the ramus, but we have a lot of things to do for this guy. And so we first decided we better fix the left main, so we've got an Amplatz and a guide. We couldn't get the guide to be exactly the right length, so we actually used an undersized Amplatz left, an AL1, with a guide liner to be able to adjust the length and get just optimal engagement and be able to pull out as we need to do the left main intervention. So I won't belabor that, but that's the final after we've stented that and IVUS that and everything. Then we did the left subclavian. I like to use self-expanding when I can in this location. put a self-expanding in there. You could argue maybe it could have been in a little further. We're, of course, trying to stay away from the lima. And the important thing is that the gradient went from 100 pre to 0 gradient. So don't need angiographic perfection if you make the gradient go away on a subclavian. So then we finally turn to this vein graft. And now this is, could argue, one of the more straightforward lesions of this patient. So again, put a filter wire in, you can see in the mid graft, position a stent, deploy the stent, post-dilate, retrieve the filter, and a very nice final result. So in this case, in 2 views, it looks very nice. So sometimes, as part of a complex clinical picture and a complex treatment plan, PCI of the vein graft is the simplest and most expedient. And even though we've got a lot going on, you notice we still used the embolic protection and still went to the Amplatz guide. I think it is a helpful thing. So to summarize all of that, I would say don't be afraid to treat the vein graft when it's appropriate, but do it appropriately with embolic protection whenever possible, and we can talk about that. And sometimes it's best when, especially you've been bitten by that vein graft before, to just bypass the bypass and go open the native vessel. A vein graft can often facilitate PCI of the native CTO, even if that vein is 100% occluded, and I think that's a good example. It goes very easily most of the time, and it's very efficient. And vein graft PCI is often an expedient choice. So I'll stop there and take questions. Thanks.
Thank you so much. We're open for discussion.
So the IFU for a lot of these embolic protection filters says keep it in the graft itself. Do you ever put it in the native vessel?
Yeah, so that can be a challenge, obviously, when the lesion is very distal, near the distal anastomosis. Sometimes you don't have room to deploy your filter without it being in the native vessel, and probably a lot of people have experience with that. You can sometimes put it into the native vessel and have the hoop be right at the anastomosis. Occasionally I've put it into the native vessel, all the way in the native vessel if the lesion involves the touchdown site. You have to recognize that it doesn't necessarily protect the other branch. You know, there may be a retrograde limb on that, and so you have to choose the one you want to protect, and you get incomplete protection. But yeah.
Are you using any proximal protection, or is that out of the market now?
It's out of the market.
Yeah,
It was great how Proxys is done.
Yeah, the Proxys was a great thing. We were part of that trial, and it's too bad we don't have that as an option.
There's a question from the audience.
So, Rick, this is Sal Lorraine from UT Houston. Thank you very much. Great talk. So, quick question, not directly related to the vein graft intervention per se, it's the opposite direction. When you fix that CTO and you still have a vein graft that's hanging, when do you decide to close it or coil it? I've never done it, though I'm told by my teachers and my proctors that perhaps you should, if you see brisk flow in the vein graft after you're done, and if it's on its way out, then just coil it on the way out. Your thoughts?
Yeah, I hear that all the time. My preference is to, especially if it's a totaled vein graft, like that one example I showed, I don't see any need to coil a totaled one. Usually at the end, it's got really no flow through it anyway. And then that other example where we were working through a tight lesion, I try not to treat that tight lesion because I just want to leave that with minimal flow through it and let it do what it's going to do. I'm not sure I've bought in totally to the idea of coiling them off to preserve my result in the native vessel. That you're putting a lot of confidence in your, I don't know. Other people
I don't think anybody knows. I mean, I've seen examples of badly degenerated vein grafts that were coiled after a successful CTO PCI. The patient comes back many months later for other issues, and the vein graft's still open with flow in it. So I don't think anybody knows.
Cool. Thank you.
Any role for laser? For example, in that case with instant restenosis, you think that you could have a laser to vaporize the plaque? So
that's a good question. I think the biology inside a vein graft is definitely different. Even inside what looks like a straightforward ISR lesion, there's probably neoatheroma, there's probably some thrombus. Laser makes sense. I don't have experience with doing laser with embolic protection in vein grafts, but it might make sense to ablate some of that thrombus that's inevitably there.
Okay. I think we're on time for the next lecture. Thank you
Great.
so much.
Thank you.
next,
So Dr. Khalili was supposed to be presenting today, but had an emergency, so I will be presenting on his behalf. And we're going to be talking a little bit about thrombus management. So we'll start with a case. We've got a 72-year-old veteran with a history of a remote CABG that presents with an end STEMI. His EKG on admission had some inferolateral ST depressions. Angiography of the left side showed a CTO of the LAD and a CTO of the circumflex, and a ramus in the diag that were with some moderate disease. He had a known atretic lima, and previous angiography had a vein graft to the OM2 that had occluded in the interim and was felt to be the IRA. So the vein graft was easily wired with a workhorse wire, and angiography following the wire advancement showed no real change in the flow. So sort of left with the question of what to do. But before we go any further, we'll talk a little bit sort of about intracoronary and sort of a large thrombus burden. So the previous classification system had used the TIMI scores, where a grade 0 represented no thrombus in the vessel, up to a grade 5, which was a complete thrombotic occlusion. However, there is a lot of ambiguity with a grade 5 lesion. So to better clarify that, the spectrum was sort of divided into a large thrombus burden versus a no large thrombus burden. And the group sort of defined this basically using the reference vessel diameter of greater than 3.5 millimeters with TIMI 0 flow, and also based off of the angiography of the thrombus. So does this even really matter? And it does, and a large thrombus burden is associated with worse outcomes. This study from 2014 by Napadano showed that patients with a large thrombus burden had a much higher incidence of distal embolization and a trend towards a higher incidence of no reflow. But besides these angiographic findings, they also found that the infarct size index represented a larger percentage of the left ventricle in patients with a large thrombus burden compared to those without a large thrombus burden. And also on cardiac MRI findings, they found that there was a higher incidence of transmural necrosis in patients with a large thrombus burden. And part of that is due to distal embolization, which we already know is associated with poor outcomes. And it's frequently seen in patients that present with an acute MI. It can be seen in up to 15% of those patients. And this is important because distal embolization is associated with a lower likelihood of ST resolution, higher infarct size, and worse mortality. So it's clear then that large thrombus burden and subsequent distal embolization are associated with poor outcomes, but does modifying that adjust any of the outcomes? The two trials that sort of come to mind are TASTE and TOTAL, and both of these looked at STEMI patients and the role of routine aspiration thrombectomy, compared to those patients undergoing routine aspiration compared to those with just PCI alone. And the results were essentially similar between the two groups, and routine aspiration was not found to be superior to PCI alone. So that led to the 2015 ACC-AHA guidelines that found that routine aspiration was a class 3 indication, but still reserved it for selective or as an option for bailout in certain cases, and that was left as a 2B recommendation. So there's been a lot of debate and sort of questions as to why both of those studies failed to show any significant difference between the two groups if large thrombus burden is associated with poor outcomes. And part of that rationale for that has been believed to be that aspiration thrombectomy was maybe not completely successful in all of those patients, and that there was still large residual thrombus burden in that group. So this group from Japan used OCT as a retrospective analysis and looked at patients that were undergoing aspiration thrombectomy and quantified the amount of residual thrombus after aspiration. The three groups were then divided the groups were divided into tertiles, and the groups in gray represent the groups with the largest residual thrombus. They found that patients with a large residual thrombus had worse angiographic outcomes, and they also found that those patients with a large thrombus burden after aspiration also had a higher incidence of a higher peak cardiac enzymes. So with the Class 2B recommendation, the question sort of remains as to who really will benefit from these therapies that are directed towards thrombus. And specifically, the patients that likely will benefit the most are those with a large thrombus burden, patients with significant residual thrombus, patients with poor flow down the vessel, a large anterior MI, or those patients presenting with a stent thrombosis. So what are our options for managing thrombus? There's really a three-pronged approach, and we'll go through each of those right now. So there's the pharmacological approaches, and the anticoagulants are the first and sort of the first step in each of this, but this is sort of a standard of therapy that we're not going to really go into right now. But the second role may be for 2B3As. And the question sort of is does the method of 2B3A delivery matter? In the study on the left, they compared intracoronary versus IV 2B3A and found that there was no significant difference. But in infused AMI, they compared intralesion 2B3A compared to no 2B3A. And this 2B3A was delivered specifically by a delivery catheter to the lesion. And they found that there was a modest improvement and a decrease in the infarct size. So the pearl here, I think, is that when administering a bolus dose of 2B3A, it's really best to do that once the thrombus has been penetrated, and if it's possible, to ideally deliver it with a microcatheter if possible. The second one that's sometimes a little bit tougher to do is to really actually let the drugs work. So the pictures on the left here are a patient that presented with an RCA STEMI. Aspiration thrombectomy was performed in the second picture here with evidence of a large thrombus burden with this improvement in the flow down the vessel, but still quite a significant thrombus burden. And in this patient, the patient was treated with 72 hours of 2B3A and returned to the cath lab for a second look with significant improvement in the thrombus burden. And then finally, the patient underwent PCI with a good result. So this can be an option. It can be a difficult option to sometimes wait for 24 to 72 hours, but this ideally should be reserved in a patient that's clinically stable. The third approach to the pharmacologic is really the vasodilators. And the goal of therapy here is to really prevent the episodes of no reflow when distal embolization does occur. And ideally, these meds should be all administered before lesion manipulation. And then finally, to round out this sort of group, we have the potent P2Y12 inhibitors as well as intracoronary lytics, which are also an option. The second prong is really the aspiration. And the two options for microcatheters are the Export and the Pronto LP. Both of these options are catheters are specifically designed for aspiration thrombectomy. And the goal when performing this is really the technique. Ideally, this should be, aspiration should be started 1 to 2 centimeters proximal to the lesion and advance slowly through the thrombus. And then while withdrawing, you want to make sure that you're still aspirating and aspirating blood from the guide catheter. The goal of this is to ideally prevent as much distal embolization as possible while maximizing the amount of thrombus that's removed. The second option with aspiration are the large bore catheters. You can use a mother and child catheter system, or you can use a guide extension catheter, including the GuideLiner or the GuideZilla. And when using the large bore options, you want to make sure that a vacuum syringe is connected to the Y arm of the connector, and that allows blood to be suctioned out of the guide as the guide liner is being removed. This picture here is just sort of evidence that's in the picture on the left. A patient presented with an LAD STEMI. Aspiration thrombectomy was performed with some improvement in the flow down the vessel, but you can see no reflow in the distal portion of the vessel. Aspiration thrombectomy was again performed into the distal portion of the vessel. A small amount of thrombus was removed, and flow down the vessel was restored. So finally, we'll discuss the mechanical options for thrombus management. The first one is the angiojet thrombectomy device, and ultimately what this is doing is a high pressure of saline that creates a negative vacuum of up to 600 millimeters per mercury that basically extracts thrombus and macerates it within the catheter and then subsequently removes it from the body. Ideally, when performing this, you want to do a single antegrade pass, which can reduce the episodes of bradyarrhythmia, and you ideally want to go proximal to distal to avoid distal embolization. The second option is laser atherectomy, which uses photochemical, mechanical, and thermal sources. Uses pulse wavelengths at 308 nanometers that allows thrombus to be vaporized, as well as there may be an antiplatelet effect in stunning the platelets and preventing further aggregation. The catheters are available in 0.9 up to 2 millimeters. And in this picture here, a patient again presented with an RCA STEMI. You see thrombus sort of in the mid portion of the vessel. Laser atherectomy was performed with a good result and allowed subsequent PCI. Ideally, when using this, you want to use a 0.9 to 1.4 millimeter catheter, and ideally you want to go slow in the antegrade. That allows the tissue to absorb as much of the energy as possible. And the third option is an open filter withdrawal. This was a case series of 9 patients that were reported in the UK. They specifically looked at a type of thrombus that was known as a cannonball-like thrombus. What they used was a EV3 spider filter, and they use a filter that is slightly bigger than the vessel diameter. It's delivered distally and then retrieved in an open fashion, and then retrieved to the guide. But you want to make sure that the neck is the only portion that's retrieved. And they found that in 8 of the 9 patients, they had a complete thrombus removal, one dissection though. And the final option is the Guard Stent. And this was a bare metal stent, not currently approved in the United States, but it was covered with an ultra-thin flexible PET mesh sleeve, and it was to help prevent distal embolization by reducing the extrusion of thrombotic material. It did show a decrease in the episodes of distal embolization. However, it was associated with more frequent episodes of stent thrombosis as well as target lesion revascularization. So returning back to our case, lesion was wired. Sort of went with a multi-pronged approach here. Balloon angioplasty was performed first. Export catheter was used for aspiration. Again, minimal improvement in the flow. And then laser atherectomy was performed using a 0.9 millimeter spectranetics catheter. And you can see that there's some moderate improvement in the flow. Now you can see the native vessel as well. Balloon angioplasty was performed, a total of 4 overlapping drug-eluting stents were placed with a good result. So that's it. Thanks.
Any questions from, any comments from the panel?
Does anybody have any experience with this penumbra catheter pump system to aspirate thrombus? Has anybody used it yet?
So we have, at our institution, we've not used it, so I didn't include it because I never used it. But I did read sort of it may be a viable option for some patients. But I don't know really much more about the specifics of that.
I mean, the results in neurointervention are pretty encouraging, so it seems like it would be a good application, but I don't have any practical experience with it.
One of my colleagues actually published a case where they came up with the idea, they called a neurointerventionalist and was able to pull a clot from the left main, large clot from the left main, after they have tried thrombus aspiration with an end-hole catheter, like Pronto or an export, and completely been unsuccessful. So it seems that there's something we're not doing with regular end-hole catheters like export, that something else may help us do.
Well, everybody's used one of these aspiration catheters where you get 10 cc's of blood and then it stops, and then you don't know what, you know, that happens all the time, and that's sort of the problem with these catheters is they don't have the ability to maintain suction.
Yeah, I mean, they tend to collapse on themselves, basically, yeah.
Yeah, I think that's a good point that sometimes it's hard to know if it's actually collapsing on itself or if it's a large thrombus that can sometimes be attached there.
Yes.
And I think that part of that can be the difficulty with this and making sure that you're aspirating from the guide at the same time as the catheter removal so as to prevent distal embolization.
You talked about angiojet. I mean, in my experience, it's been more or less disappointing. You know, you get a lot of bradycardia and you never quite clear all the thrombus. Better luck in the periphery with it, but have you used much?
So in my fellowship, I did a total of 1, so not that much experience with it. And like you said, didn't have the best result as an end result with it. But I think the bottom line sort of with treating all of these is really it's a multi-pronged approach. It's a combination of pharmacologic, mechanical, and aspiration sometimes. But sometimes you may have more success with one or the other.
So where does your practice stand with thrombus aspiration in the setting of primary PCI?
So specifically only for the large thrombus burden. Ideally, in patients sort of using that sort of criteria that we sort of showed earlier, that we do not routinely do it, but in the patient that with TIMI zero flow down the vessel with evidence of a large thrombus or some improved flow with a large thrombus, we'll go ahead and do that. For stent thrombosis, it's usually our go-to before anything.
So we have a question from the audience.
Yeah, you talked about penumbra. You know, we use the penumbra in the periphery more often, but one of the characteristics about the penumbra is they have that plunger, which is a wire and it has a little bit of a dilated part on the wire and it helps macerate the clot. So for example, in the left main case where your colleague couldn't get the thrombus into the aspiration catheter, the advantage of the penumbra is just that you can actually take a wire that has a little indentation, so it can help macerate the clot. The only problem with that, obviously, is it can send stuff distally as well. But I do think the penumbra probably could have some applications in the coronary. just to sort of macerate that sort of intermediate age clot where it doesn't suck in very well.
Okay. So we're going to go to the last lecture of the session. So we have innovation in coronary ostial lesion management with Dr. Prasad.
All right, thank you. So I'm going to wrap up the session today with coronary ostial lesions. And we've seen a few examples already of coronary ostial lesions, but I'll share with you a couple of cases, both of which were very painful. All right, so what do we mean by ostial coronary lesions? Essentially, we're talking about either aorta ostial or branched ostial lesions, ostial left main, right vein graft. And the principles that we learn from dealing with these lesions we can apply to renals, subclavians, other peripheral vessels. In branched ostials, really the ostial left circumflex or LAD really falls under the scope of bifurcation stenting, a lot of which you've already seen today. The outcomes challenges with ostial lesions are real and they persist even in the DES era with lower procedural success rates, higher complication rates, increased TLR. And obviously if you miss the ostium, which is the key here, you're going to have higher TLR rates. And not that much debate today where we really think drug-eluting stents, the data is better than bare metal stents. And I put innovation here in quotes because there's a lot of back to basics here, things that we teach our fellows that sometimes we forget when we're in a rush, but I'm just going to run through this quickly. Guide selection, very important, coaxial guide engagement. This whole issue of side holes and pressure dampening, I think we have to really understand that we can't trust side hole pressures always. It can give us a false reassurance. Lesion preparation is key, particularly for ostial lesions, where I favor rotational atherectomy, and you can have problems with orbital atherectomy and ostial, left main or ostial RCA. You can use a technique where you advance your crown in and burr on the way back, but you want to be careful with that aorta-ostial junction. The most common mistake I see is people don't define the ostium, so appropriate angiographic angles, understanding how to lay out the aorta-ostial junction, and then that plays into landing your stent, ideally hanging it out a few millimeters. Obviously, you don't want to hang it out quite a bit because then you can never really re-engage the vessel, and it's a nightmare. Also, there have been reports when people use short stents, 8mm stents, to try to nail the ostium, that it can disappear later and it can embolize out. So you want to be careful with too short of a stent. And then I think the use of imaging, particularly IVUS, is very important just to reassure yourself that you've hit the ostium and you've expanded it appropriately. And then flaring it is very important. How many of you are familiar with the Osteo Pro? Have you used it? Is it routine in your practice? So not that much. The idea here is that this is a device with these pronged arms. It really helps define the aorta-ostial junction and allows you to precisely place your stent at the aorta-ostial position. Not really taken up very much by the community, but it can be helpful. So I'm going to show you a couple of cases. The first one is where nailing the ostium is key, and if you don't, you're really in trouble. This is a male with angina, occluded RCA with LAD septal collaterals, and you can see that the RCA CTO involves the very proximal part of the vessel involving the ostium. Reverse card is attempted, but unsuccessful re-entry back into the true lumen. We switched to an antegrade dissection re-entry with a Stingray catheter and able to penetrate into the true lumen distally, so we're feeling pretty good. Proceed with the full metal jacket. We're pretty confident we got the ostium, we post-dilated. But did we really nail it? Here's our picture. And you can see that there's now a dissection of the aortic cusp there, of the right coronary cusp. We pull back, take a shot. We still feel like, hey, we've nailed this ostium. We're not confident that we need to put another stent in. But of course, the patient develops severe chest pain radiating into the back, and shortly thereafter, CT reveals extensive aortic dissection requiring surgical repair. So this is the consequences of underestimating where the ostium is and not nailing the ostium with a stent. So again, IVUS in this case is helpful. You think you have stented the ostium, you see struts, but you have to really look at that aorto-osteal junction, and you want to see stent struts hanging out in that ostium. Another case that's very painful, a 77-year-old female referred to me for a TAVR after PCI of her right by her primary cardiologist. This is the original image. You can see the heavy calcium and the tight osteal lesion. A stent's position, and, in retrospect, when we go back and look at all the films, you see that it's sort of a shallow LAO projection, so the ostium's really unclear. Where is the ostium here? It's dilated. Here's the stent deployed, and either the ostium is missed or underexpanded. Regardless, the IVUS is done, and it confirmed that there was no stent struts in the aorto-osteal junction, and there was actually persistent lesion there in the proximal vessel. So an 8 millimeter stent is then positioned at the ostium, which is obviously always suboptimal to have overlap there. It's expanded, doesn't quite fully expand, and you're left with essentially an underexpanded stent sticking out. At least it looks like the ostium has been treated this time. So she's now ready for her TAVR. We look at the right coronary artery stent. It's sticking out, which is a little concerning, but at least the coronary height looks adequate. She does have effaced sinuses, so in this case I decide that we should protect this right coronary stent. And we get access from the radial approach to protect the RCA. It's really even difficult to wire this stented right. Able to get a wire down, difficult to advance the balloon, post-dilated aggressively. Thought about putting another stent, but unable to even deliver a stent at that point. Probably in hindsight, it's better not to add more metal to this mix there. So eventually, after about an hour of doing all this, we get a non-compliant balloon down the right coronary artery, and that's going to be our protection balloon that we can pull back and post-dilate this stent if it gets kinked or crimped by the TAVR strut. So this is a 23 millimeter S3. It's deployed. Unfortunately, in this case, we still have patency of the right coronary artery. I know everybody wanted to see it like occluded or gone, but it's patent and it had flow. But it was quite concerning when we were planning out this case. We had to post-dilate it. A lot of thought went into managing this underexpanded right coronary. So osteal lesion preparation, we've heard a little bit about it. I used rotational atherectomy for that. I think in the case I just showed, if debulking that osteal right, getting that calcium treated first would have allowed better stent apposition and expansion. So generally the technique, as most of you are familiar with, is to hang your guide out into the aorta, try to be as coaxial, and then start running the burr in the aorta as you peck into the proximal right coronary artery. So making sure the ostium dilated is key, flaring it. This is the flash osteal system. Has anybody used the flash osteal here? So again, sort of specialty products that haven't really gotten widespread adoption. This is for when a stent's already deployed. The idea is use a very soft, compliant balloon, and you inflate it, and it really dilates up that ostium and flares it out and aligns it with the aorto-osteal wall. That's what it looks like when it's inflated. Again, somewhat of a specialty product. So the reality is, do we need to get fancy? And in short, I think it's back to basics. So really identifying the ostium, prepping the lesion, nailing the ostium, and then flaring and post-dilating the stent. I think these accessory devices are interesting. I haven't incorporated them in my routine practice at all, but I try to emphasize, especially with my fellows, the basics. Thank you.
I don't know if there's any comments from the audience. one question, and then I think we're on time to finish the session. So do you see any role for cutting balloons or angiosculpts in ostial lesions?
Yeah, absolutely. I think particularly for fibrotic lesions, I find the cutting balloons to be helpful. I didn't really go into it here. It can be hard to deliver them and position them. There's the new Wolverine balloon from Boston that's a lot more deliverable. That's quite helpful. I think as an adjunct to atherectomy, rotational atherectomy, or even orbital, following that up with a cutting balloon is helpful as well. Yes. Thank you.